Okay, so I will continue with the subject of pulmonary hypertension after cardiovascular surgery. This is a sponsored talk by Bayer. Well, the scope of the problem in cardiac surgery is mainly mitral valve surgery. We have mitral stenosis that is often accompanied with severe pulmonary hypertension, but in many cases the operation or the balloon valvuloplasty resolves the pulmonary hypertension as well. We don't have many patients with severe pulmonary hypertension as a complication after mitral surgery for mitral stenosis. It's different for mitral regurg. The ones who have bad pulmonary hypertension are usually very late in their natural history, and the outcome can be quite bleak, and the post-operative complications may be quite substantial. We can have aortic valve disease, mainly regurg, sometimes stenosis with pulmonary hypertension, and even coronary artery bypass grafting in patients with severe left hearts can be involving significant pulmonary hypertension with a much worse prognosis. Pulmonary hypertension post-CABG increases the likelihood of recurrent MI and death. And then we have some special groups that should get the attention. First of all, heart transplantation. We are taking a patient who has a bad heart for many years. When the right ventricle got used to combating pulmonary hypertension, and we replace it with a completely normal, innocent heart that never had to resist any pulmonary hypertension. And in the immediate post-operative course, sometimes it's the RV that suffers the most from the pulmonary hypertension post-surgery. And then there is the small group with a very important subject of pulmonary thromboendarterectomy. This is going to be discussed further this session. Now, if we go to congenital heart disease, of course, most of the patients that we are treating who have pulmonary hypertension have left to right shunts. Many of them, if we are expecting problems with pulmonary hypertension, are those in the intermediate range of pulmonary resistance, those who are borderline cases. They are almost always very difficult to handle post-operatively, but sometimes it's surprising to see a patient that has a big shunt. It doesn't have a high pulmonary vascular resistance, but post-operatively we see significant pulmonary hypertension and pulmonary hypertensive crisis, which can be difficult to overcome. Then we have the very rare cases. I'll show you one at the end, which is an anecdote with Eisenmenger physiology that need cardiac surgery. And we have the patients with single ventricles who have a Glenn or a Fontan. There we are talking about a completely different problem of pulmonary hypertension. Even 20 millimeters or 25 millimeters of mercury mean PA pressure is terrible for those patients. So the physiology is different. They don't have a pumping chamber, and we must make sure that they have a completely normal pulmonary vascular resistance to begin with and post-operatively. Otherwise, we are in trouble. Now, before I would like to address the pharmacological treatment, I would just like to say how helpful it is sometimes to fenestrate the atrial septum. This has been our policy in all the borderline cases that we did with shunt lesions. We close the big shunt, but we leave a small fenestration. This will allow some decompression of the right atrium with improvement in outcome. This is done in all Fontans, most Fontans nowadays, and in other shunt lesions. There is an increase of paradoxical embolism, and there is some cyanosis, but this is a price worth paying. And once we see that the shunt reverses, that's the good sign. This is like the pigeon in Noah's Ark. We know once the shunt has reversed from left to right, the patient is on a good track for recovery. Now, I would like to speak about iloprost and inhaled iloprost. The commercial name is Ventavis by Bayer. This is the molecule. This is on the left, we have the INEB. This is now a sophisticated adaptive aerosol delivery system that is used for the chronic treatment of pulmonary hypertension. And on the right, we see a diagram of the system that is used for ventilators in ventilated patients. Most of the patients that we are going to discuss now, of course, need this device for delivering during ventilation. Now, if we are speaking about aerosol delivery, we know that we give the drug to a very large absorptive area of 100 square meters in the lungs. We have the blood vessels very close proximity to the alveoli. We don't have a first-pass metabolism in the liver, and it's a non-invasive method. So we have many advantages giving an aerosolized drug. Now, if we want to discuss what cardiopulmonary bypass machine does to the endothelial function of the lungs, there was an assumption in the past that the vasovasorum of the bronchial vessels that still gets blood during cardiopulmonary bypass protects the endothelium, but probably this is not always the case. And there is an increase in thromboxane and endothelin and the reduction of endogenous nitric oxide and PGI2 during cardiopulmonary bypass. Of course, the preoperative condition of the patient has the most influence on the endothelial injury post-op. So the ones who go into the operation with bad pulmonary vessels come out even worse. Then it's the length of cardiopulmonary bypass. We need to do as short as possible operations in these patients, and we have to prevent hypoxia and hypercarbia, acidosis during the operation, and also to reduce the adrenergic tone and avoid atelectasis and hypoxia post-operatively. Now, this is the paper, at least in my memory, this is the first paper that I saw regarding aerosolized prostacyclin in 1996, and it drew my attention, and I was using inhaled iloprost since then. There are some works now in the literature regarding specific patient groups that benefit from iloprost. This one is about transplant patients, a small group from Greece, showing that iloprost in the operating theater improved the immediate hemodynamics of patients during transplantation. This is a paper in the same journal from a group from Germany showing a randomized study where 10 patients were being treated for severe mitral regurgitation with mitral valve prolapse. 10 of them received iloprost while weaning from cardiopulmonary bypass, and 10 of them received regular treatment with an option to have salvage treatment with nitric oxide when necessary. All 10 patients who were receiving iloprost during the operation had a completely smooth withdrawal from cardiopulmonary bypass. From the other 10, 3 needed rescue treatment with nitric oxide. Now, if we look at iloprost inhalation and we look at other medications that we are using for treating pulmonary hypertension, of course, the ones that are given intravenously have a very profound systemic effect on blood pressure, and this is a limiting factor for all the intravenously administered prostacyclins. The oral agents, of course, have a much slower onset of action, so that's not practical in the intensive care. So the biggest opponent or the competition for iloprost is nitric oxide. Nitric oxide is much more cumbersome to deliver. It needs the balloon and the titration system, and nitric oxide, after several days, eliminates the intrinsic nitric oxide reserves in the body, so there may be a rebound stopping nitric oxide abruptly, and we always need to do it gradually. This is not the case with nitric oxide and with the iloprost, I'm sorry. And there were already several head-to-head comparisons showing that iloprost inhalation has a more potent effect on cardiac output, pulmonary vascular resistance, and mean pulmonary artery pressure compared to nitric oxide. This is one of them. The red is the iloprost, the green is the nitric oxide. Now, in chronic thromboembolic disease, there is not a conclusive evidence that this is helpful during the course of the disease, but there is now a building evidence that's very helpful after the operation of pulmonary thrombectomy. So this is a useful tool. And there is some evidence now that patients who have a problem with the right ventricle after implantation of an LVAD can benefit from iloprost at the time of LVAD implantation to reduce the right ventricular pressure overload. Now, in congenital heart disease, it's quite surprising that there's not very much in the literature. There is some of the literature regarding iloprost as a test for hemodynamic testing in the catheterization lab. We have been using iloprost as a vasodilator in the cath lab for the last 15 years, and it's an excellent tool. We don't even use an INEB. We have an Omron ultrasonic nebulizer that's very easy to use in the cath lab. The patient can remain lying with a mask on the face, and we get a very pronounced hemodynamic effect, so we know that it's working. And of course, this is the pharmacological testing to see if the patient is a candidate for closure of the shunt lesion. And there has been some work showing that there is a benefit in the post-operative period giving iloprost, and in very severe cases, giving iloprost and nitric oxide in combination. We have been using iloprost in several very high-risk patients undergoing shunt surgery successfully, and I would like to conclude with one patient that I think is extremely interesting. This is a patient who was 55 years old with an Eisenmenger duct, who developed severe aortic valve disease, extremely severe aortic valve disease. He nearly died of the symptoms of low cardiac output. We catheterized him. The cardiac index was 1.4. The transaortic gradient was still more than 90. So this is the duct. You can see it here. We were speaking about it in the previous talk. So this is the duct. And this is the aortic valve disease. You can see a very hypertrophied left ventricle. And here you can see it in short axis. Really, the erythrocytes had to stand in line to get out of the heart. And this is, you can see both ventricles very hypertrophied, the left one, the right one. This is the TR. Patient had quite significant TR. This was part of his clinical deterioration. And the TR gradient is 140. If someone doubts that the patient had extremely severe pulmonary hypertension, the pulmonary resistance was about 35 Wood units times meter square. And this is the transaortic gradient on Doppler, 126/75. This is also to show that even if you have very low cardiac output, if you really have very, very bad aortic stenosis, you'll get a high gradient. There's no way out. There's no other way. So we decided to operate on this patient and replace his valve. I'll show you this picture in a minute. And the operation was successful. We had a very difficult post-operative time. He was receiving iloprost inhalations around the clock. He managed to get out of the hospital. He had some rehabilitation and he went home. He was on iloprost inhalations for 6 months. Then he was so good that we replaced it with bosentan. He was on bosentan. He was feeling well. He was coming for 2 years to the outpatient clinic, better than he was before the operation. And then, unfortunately, there was a problem with the Coumadin. I don't know why this happened. And he clotted the valve. And that's when he came back to the hospital. The aortic valve was completely non-functional. And in most patients who don't have an Eisenmenger duct, he would have died immediately. But because of the duct, he had a rescue circulation. He had the whole body perfused from the pulmonary artery. So in his case, the congenital anomaly saved his life during the stuck valve. We didn't know what to do with him. We thought another operation he will not survive another operation. We couldn't give thrombolysis because he had a huge clot on the valve. So we just gave him heparin, and we hoped he'll survive it, but after several days he had a VF and he died. But this is to conclude the role of iloprost in severe pulmonary hypertension post-operatively. So pulmonary hypertension can cause significant morbidity and mortality in a variety of cardiac operations. The routine use of inhaled iloprost in the operating theater before weaning from cardiopulmonary bypass and in the intensive care unit may improve outcome significantly. Fenestration of the atrial septum during operation is often beneficial, and I would suggest that people consider this in high-risk patients. In extreme cases, we may need the combination of iloprost and nitric oxide. And pulmonary hypertension, that's very important to take-home message. Pulmonary hypertension initiates a vicious cycle that can lead to rapid deterioration. We have to preempt this and give the treatment as early as possible in the theater and in the intensive care unit before a crisis occurs, because once it occurs, it's very difficult to reverse and the patient may die. Thank you very much.